Today I'm going to discuss about a very important topic, that is a polycystic kidney disease. So polycystic kidney disease is basically the progressive cystic dilation of renal tubules. So polycystic kidney disease is divided into the two types. So autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. So autosomal dominant polycystic kidney disease, basically the mutation in polycystin protein. So mutation polycystin protein, and that is mainly coded by two genes. That is a PKD1 gene and PKD2 genes. So this PKD1 is basically encoded by chromosome 16, and it is mainly the 85% of cases, while this PKD2 is present on chromosome number 4, and it is only the 15% of the cases, right? So autosomal recessive polycystic kidney disease, it is a less common but more severe form of the polycystic kidney disease. So it's typically present with the infant, flank masses, renal failure, liver fibrosis, portal hypertension. These flank masses may also present on prenatal ultrasound. So prenatal ultrasound also detect these bilateral flank masses, and then in the first few days of life, due to the oligohydramnios, that oligohydramnios lead to Porter sequence. So bilateral renal agenesis is typically the Porter sequence. Oligohydramnios lead to Porter sequence, and that is the cause of death of this child. Okay, so autosomal dominant polycystic kidney disease features. So it simply divided into the three types. The most patients are asymptomatic until 35 to 40 years, and then symptomatics and extrarenal clinical manifestations. Okay, so the symptoms of autosomal dominant polycystic kidney disease, that is a flank pain, hematuria, and hypertension, that is a very high yield, palpable abdominal masses, that is a bilateral, and CKD. Okay, so this is the mechanism of hypertension in the polycystic kidney disease. So what happened? The cyst expansion lead to the localized renal ischemia. This localized renal ischemia will lead to increased renal, and this renal activation of renal angiotensin aldosterone system, and this ultimately lead to hypertension. So first line of antihypertensive drug in autosomal dominant polycystic kidney disease are ACE or ARBs, angiotensin receptor blockers. Extrarenal clinical features of autosomal dominant polycystic kidney disease, cerebral aneurysm. It is a very important super high yield. Why? Because of subarachnoid hemorrhage, right? So hepatic cyst is again very important, very high yield, is a most common extrarenal cyst. Extrarenal cyst. Okay, so heart. In heart, mitral valve prolapse and aortic regurgitation, chronic diverticulosis, hernia, ventral plus inguinal hernia, and nephrolithiasis, most commonly uric acid. So ultrasound show multiple cyst, The diagnose on ultrasound usually, so ultrasound shows multiple cysts. So the treatment of the autosomal dominant polycystic kidney disease, aggressive control of the risk factor for cardiovascular diseases and CKD. So aggressive control of the risk factor, that may be the hyperlipidemia, hypertension, decreased sodium intake, right? ACE, again, ACE or ARBs are first line. These are first line antihypertensive in case of autosomal dominant polycystic kidney disease. End stage renal disease. End stage renal disease is treated by hemodialysis, hemodialysis and renal transplant. So hemodialysis is a temporary treatment while permanent is renal transplant. So this is the last slide. So it is a very important to differentiate from the simple renal cyst and malignant renal cyst. So simple cyst on the imaging, it is a thin wall, unilocular, no solid component and no contrast enhancement on CT scan. So the clinical feature of the simple cyst, it is a typically benign, most commonly in the 50 year of the patient, usually asymptomatic, no follow-up needed. So the imaging of the CT are very important to identify the simple cyst, while the malignant cyst on the CT, has irregular valves. So simple cyst has a regular wall, while the malignant cyst has irregular valves, irregular valves, multilocular, heterogeneous component, and contrast enhancements. So all these points are opposite to the simple cyst. As so management is required follow-up and urological evaluation for malignancy.